Good evening. Good evening and welcome. Shall we make a start? Thank you. Nice to see so many of you here tonight. Apologies for absence. I've heard from a couple of people, Tony Avery isn't well, St. Ali's not well, so they both sent their apologies today and said they had planned to come, but are not here. I don't know if we've had any other apologies that have been communicated to anyone, but those we've had. The last meeting, Jonathan's talk on the future of training doctors will appear very soon. I checked earlier today and it's not there at the moment, but it was recorded and I think it will appear soon. It doesn't appear on my my menu when I look for it. Those of you who've said that you can't find this year's lectures, if you are looking on the YouTube site, if you go to Nottingham Medcai on YouTube, if you click along to where it says playlists, then each of the president's years comes up and you can see all in there for the years. There was 2 or 3 years where they weren't recorded, but there's actually lectures going back quite a long way on that site if you are looking to find the old ones. Nick Maynard from earlier this year has had over 200 views, so quite a few of them are being viewed actually. Upcoming events, some of you may have seen publicity. This was the BBC mentioned this at the tail end of last year, and team who are arranging this plaque unveiling. I think the BBC perhaps slightly overstated things, but Margaret Glenn Bott, it sounds like she was a bit of a character as a woman fighting her way through surgery in obs and gynae more than 100 years ago. I think you couldn't join the Royal College of Surgeons as a woman until 1909. And she graduated in 1915 and then came to the General Hospital here to treat the war wounded in 1916. Set up, I think, in obs and gynae in 1919 and was certainly one of the pioneers. The BBC, I think, said she was the city's first female surgeon, and someone around here corrected that and said, I think Dr. Sarah Gray was probably the city's first female surgeon. But Margaret Glenn Bott was a very significant figure, obs and gynae more than 100 years ago, and also went on to become a magistrate and play competitive badminton at a high level and had all sorts of talent. So a plaque is being unveiled at the site where she set up in practice on 15 Regent Street. Saturday lunchtime. So we've been invited, and I think a couple of us have said from Medcai that we can go along. Certainly Mary and I are going to go along. There'll just be a short ceremony while the plaque is unveiled. In terms of upcoming social events, the Medcai quiz this year is going to be on Wednesday, the 29th of April at the Embankment Bar, which is always a nice venue. And David Bogod, I think, is already diving into the deepest recesses of his imagination to come up with questions that we can't answer or look up this year. So that should be very good. So get your names down in Teams for that. The ball, people have started booking for the ball, which is great. So the booking for that is through the Medcai website. There'll be tables of 10 or 12. So get together with groups of friends, please, and try and get booking for that. The go-karting, we haven't set a date for it, but it will be taking place. We initially said it would be in spring, but it's going to be in June, the departmental go-karting. A reminder that the President's charity is Doctors in Distress, and you can donate using the QR code that's there or up in the lounge where we've been, or you can do it through the website. Our next lecture in a month's time, Bryn Baxendale, is going to talk, recently retired anaesthetist and guru on simulation, is going to talk about the process of learning new skills, both in the arenas of practice of medicine and his current love of the business of brewing. So that will be in about a month's time and should be quite an interesting and diverse talk. So on to tonight's lecture. So very pleased to have Gerry Dolan joining us. Gerry studied medicine in Glasgow and trained in internal medicine and haematology in Glasgow, Edinburgh and Sheffield, I think I'm right in saying. He was consultant haematologist in NUH, and I remember him being here when I arrived. He was here from 1991 to 2015, I think, and since then, well, his research interests included molecular aspects of inherited bleeding disorders, gene therapy, haemophilia in older adults. Since leaving Nottingham, he's been a consultant haematologist in London and haemophilia centre director at St Thomas's. He's had quite a lot of responsibilities in the haematology world. He's been the clinical lead for the NHS CRG for Specialised Haematology, president of the British Society for Haemostasis and Thrombosis, and chairman of ADVANCE, the Age-Related Developments and Comorbidities in Haemophilia Working Group. Its title tonight is Haemophilia from Darkness into Light. So warm welcome, please, for Dr. Gerry Dolan.
Thank you very much. It's a pleasure to meet so many people from my time in Nottingham. And I thought there would be a bit of a flavour of my experience in Nottingham when I first appeared as a new consultant in 1991. And I think I was about 31 at the time. As you know, QMC is a huge hospital, a lot of general haematology, but there was a subset, it is a haemophilia centre, and it was in quite a bad way when I arrived, for reasons I'll explain. There was it clues in the name, so there's a bit of darkness in the first part of this talk, but it does get better, so hang on in there. So no jumping off your seats. It's also a lecture which will involve clotting, and I don't want to trigger any PTSD and lots of Roman numerals and arrows flying everywhere from your time in medical school. And on that subject, everything you learned about clotting in medical school is rubbish. So we will start with the basic issue with haemophilia. So the main physiological issue in clotting is the factor 7A tissue factor complex. So tissue factor is basically stuff that shouldn't be in contact with the blood. And it converts factor 10 to 10A, you'll probably remember a bit about this, and generates thrombin, but only in small amounts and not enough to form a stable fibrin structure. So these are very weak clots that are washed away very easily. But thrombin self-promotes, like many of our colleagues in medicine. And basically, this 9A, 8A complex together generates a thrombin burst, or a real big burst of thrombin, which then leads to fibrin formation via another factor 13. It causes platelet activation, switches off fibrinolysis, and in a self-regulatory way, it activates its own inhibitor, protein C. So that's the basis of it. And you can see from this cartoon that 9A and 8A are very close together. And so they're very similar and clinically identical conditions. So I'm going to focus on haemophilia A today. So if you don't have this component, either factor 9 or factor 8, then you can't generate this thrombin burst. So you cannot generate enough to form a stabilized fibrin network. And so the patients bleed. The platelets are not activated. Fibrinolysis is not switched off either. So that's the basis behind haemophilia. And you can measure this. So this is a thrombin generation assay showing the amount of thrombin that is generated if you try and activate the plasma of a patient with haemophilia in green compared to what it should be in red. But it also shows you that you can correct it, even temporarily, by giving or adding factor 8 to that plasma. So that's the kind of basis of the treatment. But obviously, you can see here this patient is just a horrible, swollen, boggy knee from having chronic haemophilia without any treatment. And it's been known about for a long time. The earliest kind of record is from the 4th century Talmud in Babylon, explaining the inheritance. So if a woman has a child and he dies from circumcision, and then she has another one and he dies from circumcision, then she doesn't have to do it the third time, right? But that doesn't always happen in real life. Anyway, and then this early recount of a family in America in 1796 explains the terrible bleeding. This is a family of, was it 5 or 6 boys who basically all died from very trivial injuries because they couldn't stop the bleeding by any means. But they did recognize that it was the woman's fault. So the father had 2 wives by each, and those who died were from the first wife. So the condition and the inheritance was known about for a long time. And of course, the family that we are most acquainted with is the royal family. So Queen Victoria was a carrier on this occasion of haemophilia B, and she probably inadvertently contributed to the fall of the Russian royal family. So the term haemophilia appeared in 1828 from Switzerland. Well, it was this term here, which wasn't really acceptable. Nobody could pronounce it. And so it shortened to haemophilia, and the Americans shortened it even further. Interestingly, at this time, life expectancy in haemophilia was 11. So pretty much everybody died in infancy. And another cause of darkness, this is one of the first case series of haemophilia from 1937, showing the number of people who died from fairly trivial injuries. And when I was a junior doctor in Glasgow, and you talk to the older patients with haemophilia or haemophilia carriers, they would often know about relatives, siblings, or even uncles who had died of, like, I remember one patient describing their brother died of biting his lip and choking to death from the subsequent hematoma because there was just no effective treatment. So it was a pretty horrific condition. In this case series, only 6 patients made it to 40. So things started to look a little bit better when people understood this was a condition. People had a collection of patients. And this Patek and Taylor's experiment in 1937 demonstrated that if you add plasma to the patient's, to the haemophilic blood sample, you could correct its clotting time. And in fact, in another experiment, they actually transfused the blood of different patients with haemophilia and found that one could correct the other. And what they were inadvertently doing there was demonstrating there were 2 types of haemophilia. So the patients with haemophilia B and factor IX deficiency were correcting the factor VIII deficient plasma and vice versa. And it was called anti-haemophilic globulin, and then effectively it was renamed after the numerical order in which it was discovered. So factor VIII was the 8th one to be discovered. I don't know what 3, 4, 5, 6 are, but 8 was what the name that was given. So the plasma, thresholds in plasma was the early treatment. I don't know, you probably sloshed a fair bucket load of FFP around in your own practice, but it's not very useful. It's a very weak source of coagulation factors. It contains very little factor VIII or factor IX. And in those days when people were being treated with FFP, you could only give it in hospital. If somebody had a bad bleed, you were given repeated transfusions of very large volumes, leading to circulatory overload. The cruder, earlier treatments caused life-threatening allergic reactions, and you could not dream of taking somebody to any kind of surgery or manage major bleeds. So it was not great. I wasn't around at that time, and but other colleagues in the UK were Peter Jones from Newcastle, who was an eminent paediatrician, who pretty much set his whole career looking after patients with haemophilia, was describing an earlier patient had been seen 24/7 times in 17 different doctors by the age he was 5. And Stuart Douglas, who was a professor of medicine in Aberdeen and I think Glasgow, who had a big interest in haemophilia, he's describing trying to stop a teenage haemophiliac dying or bleeding from a dental extraction. So this was all in the 1960s, not that long ago. So a glimmer of light, a big step forward when this lady, Judith Poole, who was a transfusionist in Stanford in America, discovered cryoprecipitate, which again, you will all have heard of. So basically by freezing and slow thawing plasma, you get a concentrate of factor VIII, and you also contains the factor VIII von Willebrand factor and fibrinogen. And that was an advance, and it was particularly useful for treating children because of the low volumes that they would require to correct. But Still wasn't great for adults. It still had to be kept in a freezer and then thawed. And if you think of somebody phoning up from Mansfield trying to get to Nottingham with a bleed, then getting there, then being seen, and then deciding you needed cryoprecipitate, and then telling blood bank, and then it being thawed and then delivered. It was a long, long period of time where this patient's actively bleeding. So it kept people alive, but not with a great quality of life. Very high bleed rate, extensive hemophilic arthropathy. Because of the fear of giving non-steroidals and interfering with platelet function, and also the risk of GI hemorrhage, these patients were often given opiates. And opiate dependency was a huge problem, particularly in some centres. I mean, Nottingham wasn't too bad when I arrived here. We didn't have any indigenous drug addicts, but places like Oxford used to give people Palfium, which is a highly euphoric type of opiate. And we inherited some of them, and it was a nightmare managing those patients. Very poor educational employment experience, and still a high mortality from bleeding. And it's important to be aware of this, because in this recent infected blood inquiry, a big focus was on whether patients should have been switched to cryoprecipitate to protect them from transfusion-transmitted infection. We'll discuss this in a minute. But from our discovery of cryo, that led directly to the ability to produce lyophilized factor VIII concentrate. That was in the 60s. In practice, it sort of started being used in the 1970s, and it was great for controlling bleeding. Patients could keep it at home. They could infuse it very quickly. They didn't have to come to hospital, and you could increase the factor whatever you wanted. So you could undertake surgery. It was very crude preparation. The early preparations, factor VIII was almost a byproduct in the lyophilized powder, and patients had to pretty much do the hokey-cokey to get it to dissolve. It took a long time shaking it and swirling it around. But the key thing is that the only way of producing it commercially was to batch plasma. So commercially, it didn't make any sense unless you put these huge batches of about 40,000 donors, which meant with every injection, the patient's got 40,000 donors exposure. And that is important because it wasn't really thought about at the time. People were focusing on trying to produce therapeutic product. And in fact, it was a godsend for patients. And this is a patient experience. When he was 12, he was taught how to self-infuse, which is amazing for all. I mean, some of them were 8 or 9 when they're taught how to self-infuse. And it gave him this freedom. He could travel, he could carry his factor VIII with him. And at a time when he wanted to explore life, this factor VIII concentrate allowed him a real glimmer of light. But it didn't last too long. I mean, it lasted about 10 years, but then the dark clouds started appearing. And the problem is that nobody, transfusion, blood is a dangerous drug, but the risk of getting anything from blood is dependent on your exposure. So most people would take the chances with a unit or 2 of blood, or maybe platelets, which is about 5 donors in it, or cryo, which is about 10. But this was an order of magnitude different. So if you look at the risk of exposure versus the scale of manufacture and the number of infusions. So if you have a very rare infection in the donor population, you can see that for most people, the risk is very low. But if you get up here to the exposure that patients with haemophilia are getting, you can see that in the course of a year, that exposure rate really puts them at significant risk. If it's 1 in 50,000 donors, you can see that there's deep trouble. Because again, with fairly low number of infusions, the risk is increasing quite sharply. And if it's 1 in 5,000, they can't avoid it. So haemophilia, I came as a senior registrar from Sheffield with general knowledge of haematology, but not very much in infectious disease or hepatology, but that's what we pretty much had to mug up on. Because this is basically the description of what happened to haemophilia once the introduction of plasma concentrates. So in these early 70s, concentrates were made possible. By the mid-70s, it was known that about 85% of the patients had been exposed to hepatitis B. At least 70% had documented non-A, non-B hepatitis, which is an old-fashioned term, but it is what it says on the tin. It's a transient hepatitis, usually a transaminitis, sometimes jaundice, sometimes a mild illness, but often asymptomatic, but not A, not B. And for a couple of decades, well, for at least a decade, there were reviews written about how it was a trivial infection. It was a price worth paying for treatment because it didn't cause any long-term sequelae. And it wasn't until 1987, I think it was, when the hepatitis C virus was identified that all of these cases were shown to be due to hepatitis C infection. And it says here, like 95% of patients were hepatitis C positive. In our experience in the UK, 100% of them were positive, and often they were infected with their first injection. So all of them got hep C. In the United States, about 80% of the patients with severe haemophilia got HIV. And actually in the UK, dependent on the practices of the local haemophilia centres, that varied enormously from some cities where 90% of them got HIV. In Nottingham, my predecessors were right for the wrong reason. They were not ambitious in the treatment of haemophilia, so they didn't use commercial factor VIII. So the rate here was about 30%. But the centres where there were very high rates, the haemophilia treaters were pioneers. They were trying to deliver as much protection against bleeding as they could, but they were wrong, but for the right reasons, if you like. So it was a terrible tragedy. So I think you've probably seen a lot in the news, and they use the term the affected blood scandal. And that term has only been used recently because there were 2 or 3 other major inquiries about this whole subject who came up with different conclusions from the latest one. So it's probably more correct to say it was an infected blood tragedy, which we will explain a little bit further. In the UK, the first patient was diagnosed with AIDS in 1982. The vast majority of patients were infected in the late 70s and early 80s, long before a test was available for HIV or hepatitis C. There was about 1,250 infected, and that included 380 children. And there's only 250 of those patients who had been infected who are still living because of the advent of highly antiretroviral infection and treatment for hep C. So the tragedy was that the introduction of these concentrates, which so improved their quality of life and their prospects and their treatment and their health, by the mid-1980s became the biggest cause of death through HIV and hepatitis C. The numbers of severe haemophilia patients plummeted, all during this period before effective therapy. And it remained so until the advent of effective antiviral therapy. I remember in Nottingham, where we had some children, and with David and Stephanie Smith's help, we managed them. There was no specific services. There was no HIV service apart from the GU clinic. So our patients had to go to the GU clinic with their families, and it was a terrible stigma at the time. There was no hepatitis service. There was a rudimentary hepatology service, but I spent that part of my time going to hepatology conferences and finding out about hep C and treatment with interferon, and we're trying to find out the best ways of eliminating infection from the blood supply. And this is what happened? And unfortunately, HIV and hepatitis C are relatively easy to kill because they're lipid enveloped. So you can kill them with heat, or you can kill them with solvent detergents. And the trick was to try and kill them, but not denature the factor VIII or factor IX, because already even this fractionation process, the yield of factor VIII and factor IX went way down. But a lot was, again, this was in the time where there wasn't really effective testing. They just knew there was something there and we had to do something about it. But the donors were deferred. There were a lot of discards. The pools were split into mini pools, then tested, and then large pools, and then they were tested. Then it was pathogen inactivation and removal. And then finally, the samples were tested again and then released for patients. But there was a lot of work trying to make blood safe. And it was effective because there wasn't any transmission of HIV or hepatitis C after 1987. But there was this terrible period of time when the factor we knew was likely to infect patients. And what did we do? If they came in with a head injury and a major bleed, we had to treat them. And we often had to treat them with products that we were probably infected. And then in the infected blood inquiry, you may have got the flavor that a lot of this was because we were importing US plasma, because most of the fractionators producing it were from the US. The UK produced its own, Scotland produced its own, and the Scottish National Blood Transfusion Service, and in England they had their English Blood Transfusion Service. But patients who'd only ever had Scottish or English blood still got infected. It was just that the HIV infection appeared first in the US donor population and then the UK afterwards. And so we switched all the patients to UK. There wasn't very much around, so we had to really ration it. But then there was a period of time where the Americans were heating their factor rates and killing the virus, but Britain wasn't. And so certainly in St. Thomas's, we switched patients back to US plasma, much against advice in the grain, because in the UK, they were pretty slow to introduce any of these techniques. So we're still in this dark tunnel, and then another shaft of light. So the gene for factor VIII was cloned in the 1980s, and that allowed the production of recombinant factor VIII and factor IX. So basically, you put the gene into a plasmid, transfected mammalian cells, in this case, Chinese hamster ovary, baby mouse kidney and human embryonic kidney cells were also used. And you grew them in a big vat and looked after them and nurtured them, and then siphoned off the factor VIII and factor IX that was produced. So this is totally without any exposure to human plasma, which is what the haemophilia community wanted. And that was the big advance. It was the drive. So first of all, we wanted concentrate, which was a bit of a disaster. And then we wanted freedom from infection so that we could concentrate on proper treatment of the haemophilia rather than managing or preventing their infectious disease. So let's all switch the patients. But we had these meetings with the Department of Health, and they were pretty adamant that no, they were not going to fund recombinant products. It was more expensive. They'd invested a lot in the UK transfusion practice of fractionating, and they weren't about to throw it all away. They pointed to the fact that the methods that they had introduced were effective, and there hadn't been any transmission since 1987. And we countered, yes, but what comes next? I mean, it is likely, or it's possible, that another emerging infection will come along, and we cannot just depend on it being lipid enveloped as well, because we already knew there were outbreaks of hepatitis A using these products, because hepatitis A is quite thermal resistant. And we were always very worried treating pregnant women with concentrates because of parvovirus infection, which again is very resistant. So there were examples of agents which escaped these systems. And, you know, again, would you be happy using products that there was constant rejection of the material because of infection, and hoping that there was no manufacturing process problem to treatment. So anyway, we left with a stalemate between the Department of Health and ourselves, and then maybe unfortunate or maybe inevitable, in 1995, BPL, which was the commercial end of the transfusion service in England, informed the haemophilia community of 9 donors who had been infected and died of variant CJD, and they had been blood donors. So they had contributed 23 donations, which had then been used to treat to make 24 batches of factor VIII and factor IX, which we knew for certain had gone into almost 800 patients with haemophilia. And not only that, we couldn't account for quite a large chunk of it. We don't know where the hell that went. And we had exported it to all these countries. So this was another terrible scare. And then they just told us and then put the phone down. Or that was it. Oh, and what do we do? There was no Chris Whitty or Bojo every night telling us what to do. This was before the internet, before electronic libraries. And very, it was very hot after all of this transfusion-transmitted infection. What do we say to the patients? There were some people saying, well, we don't know enough about it, so why ruin what quality of life they have? But then there was all this transparency. We know this. We know something about the patient. We have to tell them. So we didn't know whether variant CJD was transmissible by blood products. If so, was it certain to cause disease? We don't know. There was no test available, still isn't, and there was no screening of blood possible. And as you remember, John Gummer was sort of forcing his child to eat a hamburger on TV at the time. I think we all thought we were all going to get variant CJD. We all regretted those hamburgers from these dodgy stalls on a Saturday night after a night out. And in fact, because of, I suspect, looking at you were all around at that time in the late 80s, early 90s, none of you will be accepted as a blood donor in any other country. I don't know if you're aware of that fact, but just the fact that you lived through that period, you would be blacklisted. But in the meantime, the public health measures came along. It kind of forced our hand, because the question arose is, are these patients an infection risk to others? Have they been infected with variant CJD? Could they infect other people? And there was a whole load of measures were put in place. So all the patients' notes had to be alerted. When they came in a hospital, there was an alert. Surgery, such as anything on the neural tissue or spinal cord or lymphoid tissue, were all considered very high risk. So it was a nightmare. So the surgeons had to wear the full high infection risk garb, and then you had to throw away all the instruments afterwards. In all of these patients had many of them had chronic liver disease, so endoscopies for the viruses, etc., you had to throw the endoscope away afterwards as well, because there was no guarantee of sterilizing it afterwards. So we were like figures of hate from the surgical teams and gastroenterology teams with this group of patients. And the only decent thing that came out of it was that it was the final straw in our battle with the government to fund recombinant factor concentrate. But there was a bit of chaos before we could scale it up. First is we had to stop using British plasma, because it was a British disease. It didn't happen anywhere else, or at least other people denied it. And having told the patients about the horrible US plasma we treated them before, we went back to using US plasma on those patients, because variant CJD had not been described in America. But it did create this very encouraging future, particularly for the young children who'd not been exposed to anything, where they could treat them with factor concentrates, which were completely free from the risk of infection. Because it was a recombinant, you weren't dependent on a number of donations. You could scale it up to whatever you wanted. So there was no shortage of factor. and we could introduce proper prophylaxis to prevent bleeding rather than waiting. And then at the same time, there's an introduction of comprehensive care. And the UK is a very unique country because we have a very networked centre. There were all regional centres with very few, and in Nottingham, when I was there, we became one of the first of the new breed of comprehensive care centres, which were, because we could provide the whole gamut of other specialities that we depended on. So that was a good piece of news. So we could park infection for the first time. I could cancel my membership for the British Haematology Association, etc., and then focus on managing the haemophilia, which really was on a back seat for a long time. But it left us with still important challenges. One is you have to give it intravenously, and you have to give it intravenously to little children, no older than 1. So you have to start at 1 year old. And for those involved in pediatrics, can you imagine having to inject little podgy arms with factor on a regular basis? And even adults, and a lot of them were traumatized in childhood, and there was a real problem with needle phobia. And then it's a terrible drug to use, factor VIII, because it's got a short half-life. And if you're trying to introduce prophylaxis, it's just the worst one to use. So you need repeated infusions. It varies from patient to patient. The pharmacokinetics vary a lot from patient to patient. And unfortunately, in children, the half-life is the shortest. So they need more injections than anybody else. So we need portacaths. And you could never really deliver full prophylaxis, which meant that you're still exposing them to significant risk. And at this early age, then intracranial bleeding is a big concern because of injury and the fact that their factor VIII levels are not, or factor IX levels are not high enough. And then the real disaster outcome, if you don't have a protein and somebody gives it, you'll probably develop antibodies to it. And about 30% of the patients developed strong neutralizing antibodies that immediately neutralized factor VIII as soon as you administered it. And so there was no point in treating them with factor VIII. And so we had to treat them with various witchcraft potion factor conglomerates to try and produce, well, trying to keep them alive, basically, but we couldn't really treat them to any standard of care. So we're going dark, a little bit of light, and we're a bit dark again. And as I said, this is exemplified. So you give somebody factor VIII, you have to go up to that kind of therapeutic range, and it falls again, up and down. So this seesaw means they could never predict properly in the week when they were safe to do anything. And because of the nature of it, what we were asking the parents and the children and the families is inject it in the morning while you're all running around having showers and having your breakfast and trying to get ready for school and work. And it often didn't happen. The big problem in the haemophilia is compliance. We knew what we were trying to do, we knew what they should take, but they either couldn't or wouldn't comply with it. So we had this paradox: this is expensive treatment. We're spending a lot of money, and it wasn't as effective as we'd hoped because of the inherent problems with the drug. So we went from plasma-derived, we wanted recombinant, and then we wanted something better. We wanted something with an extended half-life to reduce the burden of treatment. And it worked very well for factor IX. It was actually very good. So the vast majority of patients with haemophilia B are very happy with their life. They have one injection a week or every 10 days. Their factor IX levels are always therapeutic, and they are fine. With haemophilia A, it was very difficult to extend. And I don't want to blow your mind too much, but it's basically because factor VIII has von Willebrand factor as a bodyguard in the circulation. So without von Willebrand, factor VIII disappears very quickly. So the half-life of factor VIII is intrinsically linked to von Willebrand factor. So you can't really do it just for factor VIII alone. So we wanted more. So we wanted an extended, and I said, find something that will move treatment on So we're not dependent on IV injections, something that gives continuous protection and hopefully a long half-life. And to the credit, the scientists in the pharmaceutical industry responded with a variety of means. And this has all happened in the last 5 or 7 years. And it's probably one of the most exciting periods in this very troubled history, which is probably why I hadn't retired yet, because this was all happening and I was seeing it, and there was some interesting clinical trials, there was interesting science, and there were some great results. So the first one that came along was a drug called emicizumab. It was discovered in Japan, and emi as an emoji means smile. So they had a good laugh and smile when they found that this was a molecule that they were about to abandon the whole process, and almost the last molecule they tested worked. And it was basically that this is factor VIII, and in one way you can consider that its job is to bring factor IX and 10 together. Well, in a way, a relatively simple function. And so they had the good idea of getting an immunoglobulin molecule and modifying it so that it bound to 9A and factor 10 too. And it worked. And it's not factor VIII, but that's a good thing, because it doesn't have to be given intravenously, it can be given subcutaneously, and it has very stable pharmacokinetics. So these patients can be treated every 2 weeks, and their levels are very stable. It doesn't completely correct the factor VIII. It changes them from about 0 to about 20, but that's huge in terms of haemophilia. We have patients with mild haemophilia who have natural levels about 20 that we never see outside trauma or surgery. And in fact, it works very well. So compared to on-demand, which was the old style treatment of waiting until you bled, there's a massive reduction in bleed rate. And it worked in patients with neutralizing antibodies or not. So ourselves and Cardiff were the centers who were first to trial this drug. And it was initially trialed on patients with inhibitors or neutralizing antibodies, because it was low-hanging fruit, because these patients bled a lot and had a pretty awful life. The response was dramatic. So in our center, we got referrals from other centers. And I remember one we got from GOS, a boy who was about 17, and he had 2 attempts to eradicate his factor VIII inhibitor or antibody without success. And he was costing £1 million a year just to keep going on this bypass therapy. And we had another patient who, he doesn't mind you talking about it because he's appeared to share his experience. He was born in India, which is not a place to be born if you have haemophilia, because the treatment there in the past was very rudimentary. And it's the same for a large part of the world. I think he only survived because his father was in charge of the Air Force in India, and they had close ties with Russia. So this patient was sent off to Russia aged 10, not speaking a word of Russian, to live and be treated in Russia. And he underwent a whole series of different surgeries. He had a neutralizing antibody, he was HIV positive, he was hepatitis C positive, and had terrible. This man was an orthopedic nightmare from all of his joint problems. And yet, most inspirational person you've ever met. He lives in London now. He has his own business and he travels the world, and he hasn't bled from the day he got emicizumab, which was a remarkable, and in my whole career, we've never had anything that we could use to treat this. And so being so effective in inhibitor patients, why don't we treat everybody with it? Because it works whether or not you have it. And in fact, that's what we did. I mean, the NHS did respond pretty well. We thought there would be a fight or resistance, but there wasn't. And in fact, in recent years, the proportion of patients on emicizumab compared to factor VIII is higher. And the lines are still crossing. So the vast majority of patients are being treated with this now, and not factor VIII. I didn't want to horrify you, but I've just showed us one slide of these horrible cartoons that used to be shown as medical students to say that there was a whole other range of innovative ways of trying to tackle it. aimed at trying to knock out the inhibitors of coagulation. So if you look at coagulation, it's in a balance. It's different balance in different parts of life. In neonatology, it's like veterinary medicine. It's completely off the scale of any rules that exist in other parts of life. So you can see there's all these clotting factors and all these inhibitors which balance coagulation and keep your blood flowing, and you'll get thrombosis or bleeding. And if you are deficient in, say, factor VIII, then that will cause bleeding. So the theory is that if you take away a major inhibitor, then you rebalance it, and therefore the patient will stop bleeding. And there were two interesting approaches. One was to knock out antithrombin. So you'll all probably heard of antithrombin, or antithrombin 3 as it used to be called. But as we don't know what antithrombin 1 and 2 is, it's just called antithrombin now. So basically, using a clever silencing RNA, you basically prevent antithrombin from being secreted. And it works very well. So you get this marked reduction in your antithrombin level, and it balances out the bleeding diathesis. It's an interesting concept, but it's a bit scary. I mean, I don't know if some of you may have come across people with hereditary antithrombin deficiency, where their levels are about 50% heterozygotes, because homozygous antithrombin deficiency is incompatible with life. But these patients have got high risk of thrombosis, and you're taking the levels way lower than that. And so the only protection the patient has against thrombosis is their bleeding with a low factor VIII. So the big problem is, well, what happens if you have to give them factor VIII? So what happens if they come in with a car crash or a major intracranial bleed and you give them factor VIII? What will happen? Do you have to give them antithrombin concentrate too, which is not widely available? And in fact, in one of the clinical trials, a young patient died in Bulgaria because he actually had a small intracerebral thrombus, but it was misread or misinterpreted as a bleed, and they pumped him full of factor VIII, and he clotted off every vessel in his brain and died. And that was a scare. It's still around, this drug, but it's looking for a treatment, for a disease to treat. Another approach is to take out tissue factor pathway inhibitor using an antibody. And again, it works too. So you get a reduction in TFPI, you get increase in thrombin generation, and you even get higher D-dimer levels in these patients. So it works too. But it doesn't really work as well as factor VIII. And I think that it's certainly my view, because we don't prescribe them. We have done some clinical trials, but in order to push the balance to protect against bleeding, you probably have to sail very close to thrombosis to get the maximum benefit. And then how can you be sure that day-to-day circumstances won't change and the patient develops this? And then all these clinical trials are based on a very clean, highly selected population of patients. Finally, at long last, way after the kind of tortoise to the hare, they found a way of really extending factor VIII by breaking its link with von Willebrand factor. And this has recently appeared in the UK formulary, and it is a genuine once-a-week factor VIII concentrate. There have been a whole varieties, but I think in the future it will be this drug, which is called Altuvoct, and emicizumab, which will dominate the treatment for patients. And factor VIII probably won't be used much at all. What about gene therapy? Because there's been a lot of publicity about gene therapy, and I think some of it is driven by the marketing companies of the people producing gene therapy, and I think probably in the hope of boosting share prices so they can capitalize on it and get out. So there are two ways of managing gene therapy. So you can either add the gene, such as this, so you've still got the mutated gene and the normal functional gene, or of course you can edit the gene, so you can correct it completely. But people have been very scared about this, about trying to send in little tools to chop up DNA and hope it doesn't have off-target effects. In some of the early studies for sickle cell disease, it was causing unforeseen changes, which was highly undesirable. So they've stuck with the addition. And haemophilia actually is a fairly classic and good disease to treat with gene therapy because it's easy to measure the effect. They measure the factor VIII or factor IX. You don't have to do a kind of formal bone marrow transplant like you would have to do for sickle cell disease. So basically, you package the DNA into a virus, which has been gutted, so it doesn't have any genetic material apart from factor VIII or factor IX. You inject it into the circulation, and these AAV, adeno-associated virus, is hepatotropic, so it goes into the hepatocytes and makes factor VIII or factor IX. Neat. But it's not really worked out as well as we had hoped. So first of all, AAV is quite common. I would imagine that at least 60 to 70% of you have got antibodies against the AAV. So the longer you live, the more likely you're being exposed to it, and you've got neutralizing antibodies to the vector, then the gene therapy doesn't happen. The predictability of response is all over the place. It's impossible to predict. And then there's this immune-mediated hepatotoxicity. So you do get some of the capsid antigen being recognized by the immune system in the cells which have been transfected. And you have to monitor the patients very closely because there is quite a common effect as to the immune system will attack the cells which have been transduced and kill them. It doesn't cause any liver damage, but it takes out all the cells that are producing factor VIII or factor IX, so you lose the effect completely. So there's this need for intensive follow-up. I think the people that designed these trials weren't aware of what happens to young adults in the UK on a Saturday and Sunday night, because basically these people like to go out and get wellied on a Saturday night, and basically, particularly when the gene product is being settled in, you don't want people to drink heavily. Actually, these patients probably don't drink as much as you did at their age, because I think generationally they just don't these days. But it's still an issue, and a lot of them, when they find this out, they want to proceed. It's too much, because it's for a long time that they're alcohol restricted. And then these are otherwise healthy people that need quite hefty immunosuppression if the hepatotoxicity happens. And then the duration of the response was not clear. Part of the problem is just these cells are very complicated. So basically, it's not just a matter of shoving the gene into the cell and it all works smoothly, because there's all these processes that have to happen to actually translate it into an actual protein. And in factor VIII, surprisingly, factor VIII is not normally produced by hepatocytes. It's normally produced by the sinusoidal cells in the liver. So you're asking a cell which doesn't normally make factor VIII to make quite a complex protein that is large, it's got a lot of glycosylation, it tends to misfold and aggregate. And that probably explains the marked variation. And also, these are the results of the trials to date. And you can see that they're all a bit disappointing, particularly in respect of duration. So the patients have to go through all of this, intensive monitoring, restriction on social life, immunosuppression, and then they might get 5 years, if they're lucky, without any treatment. And then they have to go back on it. So this approach, it's not the end of the story with gene therapy, but for this one, for factor VIII, they've all withdrawn the products from trial and from any form of marketing. It's different for factor IX, because factor IX is normally made in the liver. It's a much smaller protein, and it's much easier to produce. And in fact, it's commissioned now, and we're one of the centres that deliver factor IX gene therapy, but its book cost is about $3 million. I think the NHS gets it for less than that, but it's quite a hefty price. And in fact, yeah, I mentioned earlier, patients with haemophilia B, they get once a week treatment, they don't bleed, and a lot of them are, well, do I really want to go here just yet? Maybe I'll just hang around a bit longer and wait to see what therapy emerges that might work better. And then there's a recent trial which has been using CRISPR technology, which basically means cutting out the mutated gene and replacing it with the normal gene. And in fact, we are the lead for this trial in the UK, but it's quite an ethical dilemma asking, these are first in human trials for patients using a CRISPR technology in patients that may not be experiencing much of a problem with the current treatment. So it's a fairly slow recruiting trial worldwide for the reasons I've just explained. So this is probably describing my whole career in haemophilia. I came in at a time where the proverbial was hitting the fan. We had to deal with all of these issues of transfusion-transmitted infection, had to fight hard to get the best treatment for the patients. And in the last 5 to 7 years, we have it in spades. And so I'm kind of coming to the end in my career and the end of the talk. I'm sure you'll be pleased to hear. It's a real light at the end of the tunnel. We've emerged from the tunnel because a child born with severe haemophilia today will have a normal life, pretty much. You can establish prophylaxis from a very early stage, about 3 months. A lot of the pediatricians were reluctant to treat young children with this drug because it wasn't that widely tested. But it is very effective, and you can give it this early. And in fact, probably one of the first people to give it this early was one of my colleagues in Los Angeles, who had a patient, and both of his parents were very well-known lawyers in Los Angeles. And they sat him down and said, how are you going to guarantee my son doesn't have an intracranial bleed? And the next day, he'd give him emicizumab, which wasn't technically licensed for it at that time. But it's highly effective. And my colleagues in GOS who were very cautious about starting on new treatments, and they still wanted to give factor. And they had 2 bad intracranial bleeds in children before they could initiate prophylaxis, and they changed their practice pretty quickly because of the devastating consequences. Within reasons, they have a normal childhood activity, minimal medical intervention, and they can have normal education. You wouldn't be able to tell the difference between a child with haemophilia and without. And that's been probably the first time that's ever happened, that we've achieved normal life expectancy. And it gets better. So emicizumab will raise your factor to about 20%, but they have managed to tweak the molecule so that there isn't a restriction. So at the moment, no matter how much you give, you will not get the level any higher. But we're about to start clinical trials on the new variation of emicizumab, which completely normalizes clotting. For the moment, gene therapy is not an option, but it is commissioned for haemophilia B, and it will appear at some point. It might be a different virus, like a retrovirus or a lentivirus, but I think all of the patients who are born today can expect to get rid of their haemophilia at some point in their life. So with that, I'd like to thank you for your attention, and I'm happy to answer any questions.
Any questions? Gerry?
91, 92, and I worked in Edinburgh, and we had to give we used to have a collection of patients who'd come in every week for factor VIII, and we'd have to give them to it. Does that that never happens now? They don't have to come up and have it. It just seemed to be given prophylactically or whatever every few weeks.
Yeah, I mean, all of the severe patients are on prophylaxis. Was that with Christopher Ludlam in Edinburgh? Yeah,
it was.
So, yeah, there is a bit of a kind of weird situation now. So the patients born with 0 factor now don't bleed, and they've got great treatment. But the patients with moderate or mild haemophilia, these drugs are not licensed. So in fact, the mild and moderate are the new severes. So you do get the mild patients coming up because of bleeds, because they're not on this treatment. And it's problematic if they come in for surgery because they've never learned to self-inject. And we have to introduce all sorts of things to that.
5 years, because I didn't know anything about all those recent developments. One of the things I'm really interested in is the health economics of how this, because I remember when we worked together, if you had an antibody, then you were on very, very expensive drugs that were measured in tens or hundreds of thousands of pounds for a week's treatment. And because you're a haemophilia centre, the money came through a separate channel, I felt, rather than coming through the hospital pharmacy, where all sorts of blocks could have been thrown in the way. And working in childhood cancer, there were many blocks suddenly arrived that prevented you from using drugs. So really the network of haemophilia centres has bypassed that, because you started off with blood products, which you managed the transfusion, but then you got the drugs down a separate budget pathway. Is that how it's happened?
Yeah, I mean, when I first started in Nottingham, it wasn't centrally funded. So it came out of the budget. And there were several times where, I think it was David Edwards at the time, would give a financial report going, the haemophiliacs have ruined our budget this month. Because if somebody came in with an inhibit needed surgery, it cost a fortune. That was straight out the hospital budget. What happened when we agreed to treat our patients with recombinant factor VIII is that as a country, we agreed to go to the pharmaceutical companies for central purchasing. And it was enormously powerful. So basically, all of the centres agreed that there would be a contract, which was administered by the NHS Commercial Medicines Unit. And the companies hated this because they wanted to divide and rule. And it was a great thing from the point of view of probity, because we weren't making individual choices on products. It was all centrally, but we saved a fortune by doing that. So basically, we said to the companies, we can guarantee you 500 million units of this. What's your cheapest price? And of course, part of their profits is volume as well as price. So we were paying a fifth of what Belgium was paying and a third of what Germany was paying. And so we still are in that situation. Our prices for haemophilia products are the cheapest in the world by a country mile. In fact, I remember being accosted by the head of Bayer, who was kind of shouting at myself and a few other colleagues about how the US and Germany were subsidizing haemophilia care in the UK. But we have never really struggled to get the best products. We were the first country in the world to go entirely recombinant. So again, this infected blood inquiry about lessons learned, we'd already learned them, and such that had to be learned. But it is very, and even emicizumab, you know, again, we did a lot of, I was the head of the CRG at the time, and we did a lot of negotiations with the company. And again, our prices for emicizumab, we can't tell anybody else because they'd be so pissed off.
Has Mr. Trump considered putting them as part of some sort of financial pressure? Of course, he's done that with other drugs, hasn't he?
Yeah, yeah. I mean, it is now, because they're not technically blood products, they are managed by that terrorist organization called pharmacy. So we do have to, we are under the kibosh a bit with them, but we still have quite a bit of prescribing freedom. I mean, the whole thing about health economics and haemophilia, it just never works. It just doesn't work. I mean, but so when the NHS was rebooted, they realized that for rare diseases, they couldn't hand it to primary care because they just didn't have the mechanisms to get their head around these rare diseases, which cost a lot of money. So they siphoned off 20% of the NHS budget, which were managed by these clinical reference groups, which was separate. So that kind of worked for a while. But, you know, in haemophilia, about 4/5 of the haemophiliacs in the world don't get any treatment. I mean, you can imagine a country, well, an African country, trying to get their head around the Star Trek costs of haemophilia treatment when they're trying to get anti-TB or HIV medication to the patients. So it's still a major issue worldwide. In this country, interestingly, you know, there was a big loss of the population during HIV, and now catching up. So the annual cost of a patient with haemophilia is about 10, well, the lifetime cost is about 10 million. So, and I'm not sure what we do about that. Do we just let it happen, or do we, so we can do the egg selection for people that want it, but they rarely do these days. But it's an issue because the numbers are going to increase. We've been a victim of our own success. So I think we're not out of a job yet, because there's lots of other things. And in fact, paradoxically, all the milder or rare diseases which are taking up a lot more of our time. And then there's the dread issue of acquired haemophilia, which is an autoimmune condition, which is a terrible condition, is far worse. But that may be a subject of another talk some other time.